Let's say a kid is playing in the ground or jumping on the bed and somehow happens to fall on the ground on their hand with their wrist extended and their elbow extended. Now, what is this called? This is called fall on outstretched hand, a foosh injury. Okay, this can cause fractures in the bones of the arm and forearm or the hand, and the most common fracture it causes is the supracondylar fracture of the humerus, and that is our topic for today. So, we are looking at supracondylar humerus fractures. As we saw earlier, it commonly occurs in children following a foosh injury. Why is the supracondylar area affected? It occurs because this is the weakest area in the bone. When this type of fracture occurs, there can be two types. If it displaces posteriorly, it is due to the pull of the triceps muscle, and this is called extension type. If it displaces anteriorly, it is called the flexion type. And extension type, as we see here, occurs in 80% of the cases, and it's the most common type. Fragments displaced posteriorly. We can see posterior prominence of the elbow. This posterior prominence is because of the olecranon process of the ulna. And as with other fractures, we have a classification for this type of fracture as well. There's Gartlamd who gave this classification, so-called Gartlamd classification, who divided the supracondylar humerus fracture into three types. Type 1, where there's a fracture but there's no displacement. Type 2, where there's a fracture but there's no displacement, but you can see the fracture segment slightly moved. There's an anterior gap that you can see. In type 3, there's a fracture and the fragments have displaced with respect to each other. So this is Gartland's classification, type 1, type 2 and type 3. And here we see a X-ray image of a supracondylar humerus fracture, and as you see here, this is the fracture site and the distal portion has displaced posteriorly. So this is a type 3 fracture of the supracondylar area, and it's an extension type of fracture, and we see here that there's prominence of the elbow point as well. Now there's a fracture and there's fragments, multiple fragments, and where all can this fragment get displaced? So if it can go proximally, there can be proximal shift, it can go laterally, there can be a lateral shift, or a medial shift if it goes medially, or there can be a medial tilt where the fragment just tilts but does not move. Okay, or there can be internal rotation. The lower segment moves internally, it rotates internally, so this is called internal rotation. Or this is seen from the AP view. On the lateral view of the X-ray, we can see the fragments moved proximally or posteriorly, posterior shift or a posterior tilt can be identified, or even an internal rotation can be identified. Now, what is Baumann's angle? We'll see that first. If a line is drawn along the long axis of humerus and the long axis of the lateral condylar growth plate, this angle is called the Baumann's angle, right? So this angle is usually 70 to 75 degree. If there's a medial tilt because of supracondylar humerus fracture, so there's a medial tilt here, so this would stay the same, but this portion would tilt, right? So we see an increase in angle here, and when this angle increases, see the carrying angle of the elbow decreases. When the Baumann's angle increases, we see that there's a tilt and the forearm moves a little medially, so the carrying angle tends to decrease. And what is this? It's the cubitus varus deformity. So we see Baumann's angle is inversely proportional to the carrying angle. If there's internal rotation of the distal fragment, what we would ideally see posteriorly from the posterior view would come to lie laterally, and we would see the posterior segment from the lateral view. So that means the lower aspect has internally rotated, right? You can imagine it, and on an X-ray we can identify it as the end of a fishtail, so that's called the fishtail sign. Now, if you identify it as supracondylar humerus fracture and you see if the radial pulse is present or absent. So, if the radial pulse is present and the fracture is undisplaced, meaning the segments have not moved with respect to each other, there is no tilt, nothing is there. You put a POP slab and then follow up the child. If the fracture segments have displaced, then you carry on with a close reduction. We'll see the technique of close reduction at the end of the video, right? you carry out closed reduction. You take an X-ray a week or two later, and then you see if the segments are healing. If there's good healing, then you continue the POP slab and then mobilize the elbow later on. If you see that the fracture segments are not healing well, that means you should carry out an open reduction with K-wire fixation. Now, if the radial pulse is absent, you carry out immediate closed reduction. If after 1 hour following the closed reduction, if the pulse reappears, then you can continue with the POP slab and then follow up after a while. If the pulse does not reappear even after 1 hour, then you see if the limbs are pink and perfused, or if it's not pink. What does pink perfused mean? It indicates the capillary collaterals that would be present around the fracture site, right? Around the fracture site supplying the forearm. So if it is pink and perfused, meaning that there's partial blood supply which is good enough. So you can continue with the POP slab and also supervise, be under constant follow-up for the child. If it's not pink and perfused, that means there's a total deficiency of blood supply. That means you need to open the fracture site and explore where is the injury to the brachial artery, and correct the injury and internally fix the fracture. So this is the treatment protocol that we follow. And if all this is done, if the fracture is like closed, there's no open wound. If the fracture site is like an open wound and you can see the bone from exterior, that means you need to carry out open reduction and fix the fracture. Now we look at the complications that could occur if the fracture is not attended to, or there is a complication following reduction of the fracture. Okay, it can be of immediate type, early type, or the late type. Immediate type is where the vessels and the nerves which surround the area are injured. There can be brachial artery injury which can cause Volkmann ischemia. So basically the muscles of the forearm are deprived of blood, and if there's ischemia of the area, there can be necrosis followed by a gangrene that could occur. There can be median nerve injury or the radial nerve injury. Early complications would include compartment syndrome. There's a fracture which is basically a swelling in the area, and there's reduced venous return. All of this can cause reduced blood supply to the muscles, and there's swelling, there's venous congestion, there's fluid retention in the muscles of the forearm, especially the flexor compartment of the forearm. So there's this causes like a vicious cycle where there's no blood supply to the muscles at all, and there's like increased pressure inside the compartment of the flexor compartment of the forearm which is happening, and there's progressive swelling of the limb which occurs. This causes pain. So this is called compartment syndrome. The child will have pain on passive stretching of the forearm. The child will have pain especially on the flexor compartment of the forearm. Late complications that could occur, and the most common complication among all, is malunion. Malunion, if the fracture sites don't unite properly, and there's cubitus varus deformity which will happen, as we saw earlier, the Baumann's angle, carrying angle and all. Cubitus varus deformity, and this is called the gunstock deformity because it looks as such, right? And the treatment for gunstock deformity is a French osteotomy. Osteotomy meaning you are removing a part of a bone, right? So if we are the image is like viewed from posterior aspect, and this is the medial end, and this is the lateral side. The bone has now gone medially. It's a varus deformity. So we need to push this part of the bone laterally so that the angle is corrected, right? So we remove a part of the bone here and approximate these two ends. So that is what has happened in this picture, and we see that the bones here have moved from medial to lateral. So this corrects the angle here and has come to the normal angle. So this is called a French osteotomy procedure. Volkmann's ischemic contracture. Because of lack of blood supply to the muscle, on long run there can be fibrosis of the muscle fibers which can occur, which causes especially fibrosis of the flexor muscles of the forearm and the hand. So this causes Volkmann's ischemic contracture, which has the classic position as shown. The treatment for this would be a turnbuckle splint, where the splint would be placed here, and this causes passive movement. And the other thing is a Max Page's operation, where We know the flexor muscles arise from the common origin, that is a medial epicondyle. A Max Page's operation is where the muscles are released from this medial origin. Then there can be shortening of forearm bones, which also would provide some improvement. And another thing which could occur is myositis ossificans. It's a late complication. This commonly occurs if there's a massage following a trauma. Bone fragment gets displaced into the muscle, and this causes bone growth inside the muscle. That's called myositis ossificans. As a summary, what all have we seen here? Supracondylar humerus fracture. This is the weakest side, that's why the fracture occurs here. There are two types, extension type, flexion type. Extension type being most common. There is posterior prominence of the elbow. Gartlamd has classified it into three types. There can be medial tilt, which is identifying using increased Baumann angle, and which causes cubitus varus deformity, and fishtail sign on the lateral view of an x-ray that can be seen. And that we saw the treatment protocol for the supracondylar humerus fracture. We saw the various complications that can occur, and stretch pain, which occurs in case of a compartment syndrome, and gunstock deformity, which occurs in case of malunion of the bone, and Volkmann's ischemic contracture, which is basically fibrosis of the muscles, and myositis ossificans, which is bone growth inside of a muscle. And we saw that it's the most common fracture on the elbow in children, and it occurs following a foot injury. Let's suppose a child was playing and happens to fall on outstretched hand, it's a foot injury, and the fracture which occurred was a supracondylar humerus fracture. This is how the bones at the elbow would normally be oriented, right? So you're looking at it from the medial aspect of the elbow, and we see the humerus here, the lower end, the condyles of the humerus, and this is the ulna, and this is the head of the radius. Olecranon process is here. And suppose there's a fracture of the supracondylar area, and this is how it would look here. So there can be we saw that extension type is the most common, so there can be displacement of the fragments posteriorly, right, as something like we see here, right? And so we see a posterior prominence of the elbow here, as we learned before, and now we'll see how close reduction for the fracture is done. First step is traction from two sides. Okay, there'll be one person who will be pulling the elbow from here, like the forearm from here like this. So traction from here. There'll be another traction given from the arm, so this way, right? So let's assume this is the person providing that traction. So traction would be provided something like this. We should cause flexion of the elbow. So how is flexion done? The person will flex the elbow from here, right? Something like this. You see that there is flexion of the elbow which is taking place, and simultaneously there will be another person, the third person, who will hold the elbow here at the elbow, and he'll try to push this process forward. So we see that the posterior displacement, this has to move forward. So this person will do that. The person will push the elbow anteriorly at the olecranon process. So along with flexion, there will be pressure applied over the olecranon. So something like this. And we see that the fracture segments will approximate. We need to flex and apply pressure as far as possible, and fracture segments have kind of approximated. And after this is done, there will be a POP cast. The posterior elbow POP cast will be put here, and the person will be sent home, followed up after 3 weeks.